10 minutes is to speak about anatomy and try to do introduction to the scapular pathology. So this is the posterior view of the left scapula. You know very well the landmark. This is the anterior view. But the mistake is that when we speak about the scapula, the main message is that the scapula is a ring of very complex kinetic chain. So I cannot speak only of the scapula, but the more important meaning of this talk is to have very clear the concept of kinetic chain. Going to the scapula, of course, has different movement on all the planes of the space. So we have external rotation, internal rotation, posterior teeth, anterior teeth, protraction, and retraction. And it's not easy to study the movement of the scapula. And also when we speak about the reverse prosthesis, very often we forget of the scapular movement. And there is, international level, a very interesting strength to try to improve the movement of the scapula in reverse shoulder arthroplasty. That probably is one of the key points in our results. There are muscles around the scapula that are very, very important. You can see the serratus anterior, the lower trap, the upper trap, and we will spend some minutes speaking about the latissimus of dorsi. So those muscles are very, very important for the movement of the scapula on the thorax cage, on any plane. This is the right shoulder. You can see very clearly the lower trap, the middle trap, and upper trap. And under those, you can see muscles that are around the scapula. This is the middle trap, and on the left side, you have the lower trap, and the right side is very clear, the scapula. This is the left shoulder. You can see we tried, of course, to do something that is more dynamic. You can notice the lower trap, and in the most inferior part of the picture, you can see the latissimus dorsi. This is the lower trap. Once again, the right shoulder, the posterior capsula, we are trying to go under the scapula, where there is an insertion of two very important muscles. One is the subscapularis, and the other one is the serratus anterior. Serratus anterior is the key point of the scapular movement. That is the muscles that in a church with retraction, and especially with the protraction of the scapula. This is another picture that shows how difficult it is to study the serratus anterior. In my experience, I am very fond of this kind of anatomy. The best way to study the serratus anterior is from the anterior view. This is the right shoulder. You can see very clearly the pectoralis minor, the serratus anterior, and very, very interesting is in the inferior part of the picture, you can see how the serratus anterior is merging with the fibers of the subscap and latissimus dorsi. So when we speak about muscles, we have not to forget that from a didactical point of view, it's important to make a differentiation, but probably from the functional point of view, they work as a whole. And these pictures, I think, are very, very clear. Once again, this is the dynamization of the previous picture, when you can see very clearly the pectoralis minor, the serratus anterior, and the merging fibers between the serratus anterior, the subscap, and the latissimus dorsi. Once again, this is the right shoulder from the anterior view. This is the posterior view of the right shoulder. You can see how, this time, the latissimus dorsi, in the follow-through position, the right shoulder is draping the scapula and the most inferior part of the scapula, and is like something that I call dynamic stabilization of the scapula during the follow-through. Surgeons that are interested, of course, in overhead pathology, of course, I am sure they know this biomechanics very, very well. And this is a magnification because Nicole Pouriab described 3 different variations of the relationship between the inferior angle of the scapula and latissimus dorsi. So there are variants also here. This is, once again, is an anterior view of the latissimus dorsi that is sometimes used to try to recover the sternal rotation in reverse shoulder arthroplasty. This is the latissimus dorsi. And this is the anterior view of the shoulder. The rule of the scapula, we are very fast now. The first rule is trying to keep centered the humeral head into the glenoid. So when we speak about the instability, it's not only the movement of the humeral head respect to the glenoid, but very important is also the movement of the scapula respect to the humeral head. And sometimes we have functional instability that in my hand works with, the results works very well with rehabilitation. And of course, in my hand, it's impossible to change the proprioception, the neuromuscular control through the surgery. So rehabilitation is one of the key points. So I trust very much in the relationship between surgeons and physio. The second rule is trying to make a clearance in the subacromial space. I think this is very important. I don't make surgery in any cuff. Many patients of mine are treated with very good rehabilitation following the functional concept and working on the kinetic chain. What means that for different reasons, that in a very simple way, I can say the muscle fatigue, those muscles doesn't work well. When those muscles that control the scapular motion are weak, I have a protraction of the scapula. It means a reduction of the subacromial space. As you can see in this video, is the right shoulder from the back. You see that there is less compliance, less space between the acromion and the scapula. This video, I think, is important. Those are the muscles that I try to explain to you. When those muscles are weak, there is a protraction of the scapula. What means? Look at this video. The gray is when the muscles are weak. When the muscles are weak, the scapula is going in protraction because the weight of the arm and the force of the deltoid, and so there is a dynamic reduction of the subacromial space. I call this dynamic impingement. If you have a good physio that works with the kinetic chain on the lower trap and the serratus anterior, and you are able to make a recovery of the retraction of the scapula of your patient, they can improve, even if they have this kind of lesion without surgery. I think that the relationship between the posture, muscle fatigue, kinetic chain, and the cuff is like when we try to save our wheels, improving the equilibrium of our car. The third rule of the scapula, of course, is very, very important. It's pure biomechanics. Try to figure out this is the right shoulder, red line, the supraspinatus. If I want that 100% of the force of the supraspinatus is applied to the humerus, I need a very good stable scapula, the chain. You can see so. I move my humerus, 100% of the cuff is going on the humerus. But if on the other side I have a very weak scapulothoracic muscles, what happens? Because the weight of the humerus is more respect to the weight of the scapula, something like this happens. And of course, this is impossible in true life, but in true life it's possible that we have a weak scapulothoracic muscles. This means that we have an overload on the cuff. And in my experience, according to the type of sport, the type of job, over time this can lead to cuff lesion. And once again, rehabilitation in selected patients can work very well. So when we speak about the scapula, we have to keep in mind that most of these muscles' origin is a level of the core. So the core stability in the inferior limb, and I intend with these words, the kinetic chain, is very, very important. So when we speak about the scapula, never forget that there is a flow of energy from proximal to distal. Going back, this is very important also in overhead throwing sports. Try to figure out these patients. This is the leg drive, is left-handed. You can see on the right side, you have the right foot is the leading leg. The back one is the back leg drive. We have a leg drive that is the distance between posterior and anterior foot. And if the kinetic chain is working well, transfer all the energy like a funnel to the scapula, and we have a good movement. So all we make rehabilitation, focus your attention not only on the scapula, but all on the kinetic chain. At least, but not last, I would like to spend you some seconds on the pure biomechanics of the scapulothoracic joint. Under 80 degrees of motion on the scapular plane, most of the motion is glenohumeral joint. You can see the video on the right side. Under 80. Most of the movement is in the humerus. The scapula is stable. So there is a lot of work, according to the talk, to the moment of the upper trapezius and the lower trap. But I think very, very important is to keep in mind that after 80 degrees, there is a scapular movement. And I would like to focus the attention with you on this last video that for me is very important. I did this video with Ben Kibler, that is a friend of mine since many years, and we divided the scapular movement in 4 phases. This is the 4th phase, where of course there is a movement, I can say only of the humerus, under 30 degrees. But very important is to introduce the concept of center of rotation of the scapula, that is a line running for the base of the spine of the scapula through the sternoclavicular joint. At this point, the scapula is rotating around a center of rotation that is moving from medial to lateral, and there is an elevation of the sternoclavicular joint. After 90 degrees, there is an important rotation. This is the key point of the clavicle that make like a bypass of force on the coracoid, taking the scapula in retraction for a very good elevation. So I think that to know this kind of biomechanics is one of the key points to improve our knowledge on the scapula. And the scapula is important not only on the cuff, as I said, but also in stability. And according to the Moroder classification, I think that many patients that I used to treat with surgery maybe 15, 20 years, today with a good diagnosis, with a good team, I think to the physiotherapists, we can have excellent results. Thank you very much.